Bismillahirrahmanirrahim. Doctors, so today is our first class on November 2025 recalls, and this recall session is conducted by the AMC Prep Academy. So this is the first platform in Pakistan that's covered and delivers the complete lecture of AMC examination. So, and this session is extremely important for all of you, those who are going to appear in next this year exam as well, early month as well as in later months of the 2026. And we will try to discuss the each and every topic, and we will try to finish complete topic from the recall topic as well, because this is extremely important. For example, if you find any question from one topic like UTI, for example, one recalls from UTI. So you have to finish the complete topic of the UTI, the sign and presenting complaint, as well as diagnostic part, investigation part, what are the management part. So quickly you have to go through the topic from the guideline, because every student have different question. Topic will be same, but the presentation of the question will be different. For example, the AMC ask your colleague about the diagnosis from the UTI, but another person will face question from investigation. Another person will face from question from management. So that's why it is highly recommended. You have to go through the complete topic from the guideline. Okay, so let's we start with our today's first question. So first question. So first question is pyelonephritis, woman, severe allergy of penicillin. What are the treatment of choice? So option A is penicillin, option B is cephalexin, option C ciprofloxacin, option D meropenem. So guys, what do you think about this one? Hurry up, please write your question in chat box. I need your active participation, so that will be more beneficial for you, all of you. No matter it is right and wrong, just give your opinion. So we will discuss with the guideline. Don't worry. So doctor, I will give you the hint. So focus on this one. This is a severe allergy. Severe allergy to penicillin, not mild. This is severe. Some people with B, some with C. So B. Okay. So other people opinions. Dr. Hashim with D. Okay. Okay, doctor. So let me show you the therapeutic guideline, which is one of the superior guideline of Australia regarding management. So then we will come back again to this topic. Okay, so doctors, this is the therapeutic guideline of pyelonephritis. Okay. Firstly, we will go with the clinical features. So what are the clinical feature of the pyelonephritis? So patient present with the flank pain, nausea, vomiting, fever, and costovertebral angle tenderness. So this is the presentation along with the urgency, frequency, and dysuria. And these are the feature of the acute cystitis as well. So it means patient systemic ill. Okay, fever, nausea, vomiting, flank pain, along with urgency, frequency, and dysuria. Okay, so what are the investigation? So this is the important. Many question you will find out the investigation as well. So the investigation of choice is the midstream, a urine sample for microscopic culture and susceptibility. So this is also the investigation of choice. So must know about this, extremely important. Okay, and also you can send the collect blood sample, culture and susceptibility testing before starts the antibiotic. You have to send the culture first. Okay, so how to manage this? So in mild cases, we have to start from the oral antibiotic, augmentin, amoxicillin plus clavulanic acid. Okay. So you have to start the empiric oral antibiotic therapy for pyelonephritis in non-pregnant adults while waiting the result of investigation. So you have to start straightforward. After taking the blood sample, start with augmentin. Okay. And in non-pregnant adult with hypersensitive to penicillin, use ciprofloxacin. So C here is our answer. Okay. Ciprofloxacin, you can go with the ciprofloxacin for those who have hypersensitivity to allergy. Okay. So you can also go for those patients who have modified empiric therapy on the result of culture and susceptibility testing if pathogen is suspected one of the following regimen. So if resistant suspected, you have to stop the combination of amoxicillin plus clavulanic acid or ciprofloxacin and use the narrow spectrum, which is the amoxicillin, or you can go with the trimethoprim or sulfamethoxazole, or you can go with the cephalexin. Anyone you can choose. Or so the first line is always remember this, the amoxicillin. And if patient have allergy, so you have to switch the class. Okay. So this is the mild allergy, not severe allergy. So what about the severe allergy? Okay, before going to severe allergy, we have the treatment of sepsis for treatment of adult with the septic shock or sepsis. So in this condition, you have to start the IV antibiotic. Okay, intravenous therapy for acute pyelonephritis. Those who are like systemic ill and their vital unstable. So you have to go with the gentamicin drug of choice. Okay, for those who are ill, or you can choose the tobramycin. So these are the investigation antibiotic of choice in case of where there is a septic shock, hemodynamically instability. So you have to go straight forward with the gentamicin and tobramycin. This is IV. Okay. Or if patient have the contraindication to these drug, you can switch the class into the cephalosporin, ceftriaxone, the third generation. Okay. So for non-pregnant patient who had a non-severe allergy or delayed allergy to penicillin on above regimen, you have to go for like ceftriaxone. Okay. This is the non-severe allergy, not severe. So this word is important. If non-severe allergy, you can go with the ceftriaxone. Okay. And for those patients who have severe allergy to penicillin, you don't add cephalosporin class. So in this condition, if patient has severe allergy to penicillin, you have to go for gentamicin or tobramycin as we discussed above. Okay, so what are the key points? So in a normal patient without any allergy, the first line of drug is penicillin, okay, amoxicillin. For those patients who have a non-severe allergy but delayed allergy and non-severe, you can go with the cephalosporin class, use ceftriaxone. For those patients who have severe allergy and extremely severe allergy, in this patient, you have to go with the gentamicin. So these three drugs you must know according to the different situation, and they are repeatedly questioned. Make sense, doctors? Should we move to next? Is it okay? Doctors, does the things make sense? For first time, I know it is a bit hard to understand, not to understand, but memorize. So the first line antibiotic is penicillin, okay? Penicillin. And if patient have mild allergy or non-severe allergy, you can go with the ceftriaxone. If patient have very severe allergy, immediate allergy or severe allergy, you have to switch the class to another like gentamicin. So these three conditions you must know. And in case where there is a patient is hemodynamically stable, so you can go with the simple to ciprofloxacin. There is a class of fluoroquinolones first generation. Okay, back to the question. So let's we see here. So answer is ciprofloxacin because the patient have allergy. Yes, Cipro is correct answer here. The thing is that the patient has severe allergy. So that's why we have to go for the penicillin. If patient have mild allergy here, like for example, mild allergy or non-severe, as we discussed from the guideline. So non-severe case, you can choose ciprofloxacin. Sorry, ciprofloxacin. Sorry. Okay, so in severe allergy, you have to totally switch the class because in cephalosporin there is also strain of allergic strain, penicillin strain. So that's why you have to totally switch the class to another class. Yes, if gentamicin will be mentioned, so gentamicin will you have to go in gentamicin in case where there is a patient hemodynamic unstable. Okay, like there is a septic shock, sepsis. So in this case, you have to go for IV gentamicin. Okay. So and admit the patient and starts IV gentamicin, or you can choose the tobramycin. Okay. So the things we discuss is enough for your exam in this topic. And what about the investigation? So investigation, as we discussed, you can choose the midstream urine. Okay. Midstream urine, take sample from midstream and send microscopic culture and susceptibility. Okay, doctors. And pyelonephritis patient, pyelonephritis means there is inflammation of kidney. So kidney inflammation, it means it involves the kidney as well. So the patient present with the urgency, frequency, dysuria, along with the systemic illness like fever, temperature will be raised greater than 30. So as well as there is flank pain, post-vertic angle tenderness, along with the nausea, vomiting. So this is the presentation of the pyelonephritis. And doctors make sense. Should we move to next question? Please hurry up. We have a lot of things to cover. Okay. And management we discuss. So here you can see that if there is severe immediate allergy to penicillin, you can choose the ceftriaxone. Okay. So sorry, in case of mild allergy, you can choose the ceftriaxone, but in case of severe allergy, you can choose the gentamicin or tobramycin. Okay. So this is all about UT, pyelonephritis. So next question. Next we have patient already high risk, want to know if he has coronary artery disease. So there is recalls from recallers, not enough information to make the diagnose. So I choose no treatment, already high risk. So exertion test was done. So medical management for high risk CVD. So in case of high risk, you have to go for the medical management because there is high risk and already have a lot of comorbs. So you have to go with the straightforward. So let's we discuss from here. So in case of high risk, we have a risk category: high risk, low, intermediate risk, and low risk. So low risk mean CVD, low risk mean less than 5%. It means there basically what is this CVD risk assessment? It means it is tool to calculate about the heart, any comorbid condition, and heart functioning as well. So if there is a low less than 5%, and what are the management if less than 5%? You have to just encourage sport and advise healthy lifestyle. And pharmacotherapy is not routinely recommended in case of there is a low uh, CVD risk less than 5. What about the reassessment interview? So reassessed risk every 5 yearly. Okay, so you have to like just a screening, you have to reassess every 5 yearly. What about the intermediate in which there is 5 to 10% CVD risk? So in this case, you will go with the encourage sport and advise a healthy lifestyle, as well as consider blood pressure lowering therapy and lipid modifying pharmacotherapy depend upon the clinical presentation. So in intermediate category, you can add the BP lowering agents as well as the lipid modifying pharmacotherapy. It's depend upon the patient to clinical presentation and symptom. Okay, so reassess in this patient because there is intermediate risk and can uh, go for high risk. So that's why you have to reassess every 2 yearly. Okay, if not currently receiving pharmacotherapy to reduce CVD, so assess sooner if close to the threshold or high risk. So the point to remember, key point. So in this intermediate risk, you have to assess the risk every 2 yearly. Okay, and in low risk the assessment will be 5 yearly. So these are MCQ. So and pharmacotherapy in intermediate risk you have to consider in case where there is patient have a symptom, so accordingly you can add. So what about the high risk? So high risk the lifestyle modification same, but you have to prescribe the blood pressure lowering therapy and lipid modifying therapy. So in high risk, it is compulsory you have to prescribe the medication because in high risk, the patient definitely have a lot of symptoms. So that's why you have to prescribe this medication. What about the reassessment interval? So in this, formal reassessment of CVD risk is not generally required. So high risk status requires clinical management and follow-up supported by ongoing communication. So basically here the patient needs the management, okay, not the reassess. So you have to treat and manage the symptom. Make sense, doctors? Should we move to next? Doctors, is it okay? Okay. So key point, there is intermediate risk. Do you have to reassess every 2 yearly? In low risk category, you have to assess every 5 yearly. And in high risk, no need to reassess. You have to, because this patient is high risk, so you have to require the clinical management and support ongoing communication. So next question is question on serotonin. Recaller didn't mention about the statement here. So let's we quickly go through with the differential point. How to assess low or high? So doctor, see here, this one is low category. So in low category, it is the CVD risk less than 5%. Okay, and pharmacotherapy is not recommended. In high risk, you will find out there is patient have a lot of symptom like high blood pressure, lipid triglyceride will be high. So it means patient is symptomatic in case of high CVD risk. Risk factor like there is blood pressure, there is obesity, increased fat, lipid. So these are the risk factor for cardiovascular diseases. Okay, make sense, Dr. Payal? Yes. So the patient basically what are the means of CVD risk? If patient have a lot of symptom regarding to the CVS system, hypertensive, obesity, or increased triglyceride, it means the patient is symptomatic. You have to consider in high risk. So you have to treat this condition. There is a no score, but there is percentage greater than 10% CVD risk. So accordingly, you have to manage. Yes, high and low as well. Okay, next question is serotonin syndrome. So this one is also a question, repeatedly question. So we have neuroleptic malignant syndrome as well as serotonin syndrome. So what about the neuroleptic malignant syndrome, in which what are the causes? Causes dopamine blockage. Okay, so dopamine antagonist, antipsychotic, metoclopramide, or sudden withdrawal of the levodopa. So these are the causes. For mild allergy, it is Cipro, and for severe allergy or complicated, it is cephalosporin and gentamicin. Sir, why didn't we choose? Our doctors uh, made it simple. So in case of there is a where you can see is mild allergy, you have to go for cephalosporin, ceftriaxone, or you can go with cephalexin. Okay. If there is a very severe allergy, immediate allergy, severe allergy, you have to go for gentamicin. Okay. And if you can see there is a patient is hemodynamically unstable, you can admit the patient and start IV. Doctors, in this question, you can see here we choose the ciprofloxacin. Why? Because they didn't mention about the patient hemodynamic stability as well as other things. So that's why in this question, the most appropriate answer is ciprofloxacin. Yes, exactly. Widely unstable severe allergy, you have to go for gentamicin. And here is no any option of gentamicin. Yes. So the most appropriate answer is ciprofloxacin. So just mention the patient has severe allergy. So in this case, you have to go. Okay. Yes. A doctor, yes, see here. So we already discussed. So the okay, for a non-pregnant adult with hypersensitive to penicillin, you have to go for ciprofloxacin 500 mg orally. So this is orally. It means patient is stable. You don't need to admit. Just give the tablet and discharge them. Okay. And for severe allergy and patient hemodynamically unstable, you have to admit the patient and start IV antibiotic. Okay. Okay, doctor. So we are talking about the neuroleptic malignant syndrome. So what are the causes? Causes is important. You must know what are the culprit. So the dopamine antagonist, antipsychotic, metoclopramide, or sudden withdrawal of the levodopa. So these are the drugs which can cause the neuroleptic malignant syndrome. So onset days to week after starting the increasing drugs. So what about the pathophysio? So you don't need to remember this. So finding about this lead pipe rigidity and hyporeflexia. So these are the important. You must know. You have to differentiate from serotonin syndrome as well. So lead pipe, there is rigidity and hyporeflexia. In case of serotonin syndrome, there is hyperflexia. Okay, and in NMS, there is hyporeflexia. Okay, so autonomic instability will be very prominent: fever, increased heart rate, PP, and diaphoresis. Mental status will be stupor, delirium, and mutism. Temperature will be extremely elevated, so it goes around the 40. Pupil will be normal. Okay. GI finding none are mild. So CK will be raised in this case. What are the diagnosis? So clinical finding occur and as well as history of dopamine antagonist use. So basically the diagnosis will be clinical. Treatment, first of all, you have to stop the offending agent. Okay. So in NMS, what are the treatment of choice is dantrolene. Okay. or you can add the bromocriptine or amantadine. Okay. What about the serotonin syndrome? So in this patient, what are the causes? The patient can take SSRI, SNRI, MAO, MNDA, linzolid, or tramadol. So you will find out these types of medical history in patient medical history. Okay. So onset within hours of the serotonin drugs. Here you can see there is a day to week. But in serotonin syndrome, the effect will the patient becomes symptomatic within hours. So increase serotonin. Okay. So hyperflexia, clonus, and tremor. Okay. So autonomic, you can find that there is a prominent heart rate, diaphoresis, and diarrhea. So it means the feature both sides same. So the patient, what about the mental status, agitation, confusion, and rest? And pupil will be dilated, hyperactive bowel syndrome, and diarrhea. So, doctors, what are the differential points? So, what are the things, how you can differentiate? So, the important one in uh, neuroleptic malignant syndrome, the pupil will be normal. But in case of serotonin syndrome, the pupil will be dilated. Okay, one point important. And as well as the patient have diarrhea. So, this point is also important. Okay, so this is the differential point. Okay, and hyperreflexia. So if 3 points you know, you can make the diagnosis easily. It is serotonin syndrome. So dilated pupil, hyperreflexia, as well as diarrhea. So think about the neuroleptic malignant syndrome. Okay. So the same, like firstly, you have to stop the offending agents, stop serotonin drugs, and you can go with the benzodiazepine or cooling. So basically, in most of the recalls, you will find out stats how to make the diagnose. What are the differential point? Yes, in serotonin, you can see there is a dilate pupil, okay, as well as diarrhea. So dilate pupil plus there is diarrhea, okay, as well as hyperreflexia. So if you know these features, you can make the diagnosis. It is in serotonin syndrome. And in case of neuroleptic malignant syndrome, the temperature will be high. So the typical point is temperature will be high, extremely high, and the patient have hyporeflexia. Along with there is autonomic instability, diaphoresis. So these are the points you can make the diagnosis. Doctors make sense. Just give a read after on so you can understand. So NMS, the patient have very high fever. Okay. Along with hyporeflexia. Okay. So and history of there is dopamine antagonist. So think about it. Okay, doctors, move to next. So this is the question from eMedici. So quickly give read. A 27-year-old man present to the emergency department with several hours of feeling generally unwell. Okay. So excessive sweating and anxiety. Okay. So excessive sweating. So this is the key point. Excessive sweating, as we discussed, diaphoresis as well. So so there is a feature of this one is diaphoresis is feature of uh, neuroleptic malignant syndrome. So first point, an anxiety. He described having muscle spasm. He has medical history of asthma and depression. Medical history has salbutamol inhaler and fluoxetine. He binge drink alcohol several times per week and last night at friend birthday party had 6 beers, 5 vodka mixer and tried tablet of MDSA. He is normally a non-smoker, but at the party last night he tried some cannabis mixed with the tobacco. So he felt short of breath afterward and used the salbutamol inhaler without spacer to some side effect. On examination, he appeared uncomfort, visible shaky and sweaty. So his blood pressure is 130 by 78, pulse is 122, regular temperature is 37.1 and respiratory rate 12. Saturation of oxygen is normal at room temperature. Pupil is converted at appropriate, but are grossly dilated bilateral. So neurological examination reveal hyperreflexia and lower limb with the several sustained beats of clonus at night. So strength has is 5 by 5 bilateral tone and coordination are intact. So which one of the following is most likely explanation of his symptom? So the serotonin syndrome. Okay, the man is most likely suffering from serotonin syndrome due to the overstimulation of serotonergic receptor in the central and peripheral system, causing autonomic dysfunction, sweating, tachycardia, myocarditis, and hypertension, AMS. Okay, as well as neuromuscular excitation, tremor, hyperreflexia, and clonus. So it is caused. The man is likely suffering from the serotonin syndrome. So due to the overstimulation of serotonergic receptor in the central and peripheral system, causing autonomic dysfunction, sweating, tachycardia, myocarditis, as well as hypertension, altered mental status, and neuromuscular excitation. So it is caused by the new antidepressant use in increase in dosage or the MDMA. So this is likely a mild moderate presentation and would be managed by immediately discontinuing his medication. So you have to firstly stop the offending agents and rest of the other option. So serotonin syndrome is potentially complication of antidepressant. And serotonin syndrome presents with a triad of autonomic dysfunction, altered mental status, and neuromuscular excitation. So this is a triad. Okay. Next question. So patient has previously history of breast cancer, vital are stable, and patient have suprapubic pain. Okay. On imaging, bladder cancer is found, which is the primary site of metastasis. So option A, lungs, option B, brain, option C, colon, and option D, kidney. So basically patient have history of breast cancer, vitally stable है. So and patient have suprapubic pain and it means there is metastasis. So imaging bladder cancer found. What are the primary site? Doctors, what do you think? Other doctors? Yes. So correct answer is A. So lungs. Okay. And the colon cancer mostly migrated to liver as well. Okay. So this is important as well. Okay, move to next. Next we have patient unable to comb hair and lift hand. Vital stable, hypertensive, diabetic. What may be seen in this patient? So doctors, the first option is anti-Rho antibody, anti-Law antibody, and option third is elevated DSR. So firstly, tell me what is the diagnosis, what you are thinking? What is the diagnosis? The most of the people with the A few with dermatomyositis, some with okay, polymyositis, and some with dermatomyositis. Okay, so you people are thinking about wrong. So the diagnosis is basically here we have uh, the temporal arteritis. So the key point to think there is patient is unable to comb hair. So it means there is involvement of the temporal lobe. Okay. So temporal lobe involvement and patient can't able to do this. So what are the investigation? So the initial investigation before going to biopsy, we have to go with the, just a second. So we have to go initial with the elevated ESR. Yes, doc. The recaller didn't mention much about the history, but according to this scenario, the comb hair is the point where you can think about that. We have also another case about uh, the polymyalgia rheumatica, in which you can find there is weakness. So here you can see that this is the reference. So in study, you have to go with the increase. The initial step, you can go with the ESR. Okay. If asked about the initial, this is from the med bullets. And if asked about the most appropriate gold standard test, the confirmatory, you have to go for temporal artery biopsy. Okay. So diagnostic. So doctors, this question is not too clear, but according to the scenario, comb here and left hand, so we can go with the elevated DSR, and this is the initial choice in case of temporal arteritis. Not too much clear about uh, clear statement. So that's why we are emphasizing on that. You have to go through the complete topic in exam scenario, because the recorder didn't can't able to memorize all this stuff. So this is the recorder wise. Okay. So this is the reference. You can go at your own time. Giant cell arteritis, a med bullet. So, or should we go through? No. What do you think, doctors? Should we move to next, or should we go with the guideline? Okay, next. Okay, so next question. Dr. Sana guideline. Okay, doctor, just quickly, we will go with that. Okay, giant cell arteritis, we also call this. So basically clinical presentation, the temporal artery, cranial artery. So the patient feel difficulty to comb hair like this presentation, and incident will be systemic vasculitis affecting greater than 50 year of age. Okay. So temporal artery jaw claudication, amaurosis, and as well as the symptom of polymyalgia rheumatica. Okay. So see here, there is also have association with the polymyalgia rheumatica. Okay. And morning stiffness. So you have to think carefully. So what about the physical examination? On physical examination, there is scalp tenderness and palpation of the artery may be demonstrated. So the tenderness on the temporal area and scalp tenderness, vision loss. due to the amorous phagosis. So amorous phagosis means there is a transient vein loss, maybe due to the any thrombus or embolus formation due to decreased blood supply. So transient vein loss, we called as amorous phagosis. Okay, what about the imaging? So imaging, the choice of imaging is initial. In case of temporal arteritis will be ESR. Okay, and ESR will be raised in this case. And what about the diagnostic? If asked diagnostic, you have to go with the temporal artery biopsy. Okay, and to assess, you can go with the Doppler ultrasound as well. But the investigation of choice initial will be ESR, and the best is the temporal artery. So what about the differential? Is migraine? You can go with the take so arthritis. So distinguish factors as well. So treatment. So treatment simple. You have to start the high dose corticosteroid as soon as possible. If you delay the treatment, the patient can go the permanent blindness. Okay. So start high dose glucocorticoid, and later on you can confirm the diagnosis with biopsy. Okay. So corticosteroid indication standard initial for patient suspecting temporal arteritis. So as soon as possible start this. Complication patient go to blindness if you delay this treatment. Okay. Move to next. Okay, doctors. Next question. High academic mark scoring patient after a recent accident. So stop it hanging out with friend. Marks drop. Want to be alone in her room. So during accident, she claimed she heard a voice calling out to her esteem. So but she's unable to make out who that was. So basically, this case is from psychiatry. So option A, delirium. B option, delusion. Option C, schizophrenia. Option D, PTSD. Option E, depression. Why, doctor? Most of the people with the PTSD, why? She claims she so focus on this. She claims she heard a voice calling out to her esteem, but she is unable to make out who that was. But there is a depression, no criteria of depression fulfilled here. So in depression, you have to at least out of nine, five symptoms should be present and which persist for greater than 2 weeks. So think about first three. PTSD, depression, rule out. So the important point which you have to focus, this is the story just like this. So she claims, so question which will help you make the diagnosis. She claims she heard a voice calling out to her esteem but unable to make. So it means there is psychotic problem here. Yes. So the answer is schizophrenia. So in schizophrenia, we have hallucination as well as delusion. Okay, hallucination and delusion. So in hallucination, there is you can see voice. There is auditory hallucination. So the patient is claiming that she heard a voice, but in reality, nothing like that. So it means patient have auditory hallucination. Okay, so the this is the schizophrenia here. In delusion, the patient claimed that like there is a fast and firm belief in case of delusion. Fast and firm belief. Like the patient claimed that the president of America is talking to me. There is a fast and firm belief, nothing reality. Okay. And in case of hallucination, might be there is a visual hallucination as well as auditory hallucination. Visual mean the patient claimed that some snakes are crawling on my room as well, on room wall. And might be auditory hallucination, I am listening something like something special, some voices are special for me, but in reality there is nothing like that. So this correct option is schizophrenia. And about the depression, there is a no DSM-5. There is a no any typical history. Depression have totally different history. Like there is sadness, depression, suicidal thought, insomnia, loss of appetite. This is another topic. So, and these features should be present at least persist for greater than 2 weeks, and out of 9 symptoms, 5 symptoms should be present, including anhedonia as well as loss of appetite. So this is another question. So move to next. There is next question is diabetic patient, ulcer on dorsum of the foot noted, oozing with pus and blood, non-tender. What is the next best step? So next step, option A, IV antibiotic. Option B, surgical debridement. Option C, check blood sugar level. Oh, so doctors oozing with pus. So it means uh, there is a point to think about that. So oozing with pus means there is a dirty ulcer here. Okay, easy. Yes. So majority with the option B. So you have to go with the surgical debridement. No imaging in option. So the surgical debridement. So this is the mnemonic from RACGP guideline. So you have to approach like this. Okay. So descending way. So metabolic medication, first step is metabolic. This is the mnemonic of med or dot. So remember this mnemonic. Approach accordingly. So metabolic causes assessment, debridement, antibiotic, then dressing, then offloading, then you have to refer and then educate. Okay. So in debridement, in our answer, so surgical debridement, diabetic foot with necrotic or unhealthy tissue. So it means there is oozing with pus, necrosis, and some unhealthy tissue. So you have to go with the debridement. After debridement, so this is important point. After debridement, you have to start the antibiotic. Okay, with the appropriate antibiotic on the basis of severity of the injection. After this, you have to start go for the dressing. Perform frequent wound care with adequate dressing. After that, offloading patient with diabetic foot wear appropriate offloading shoe to reduce the plantar pressure. And after, if there is all these things are insufficient, you have to refer. Okay. So multidisciplinary diabetic foot optimal management. So doctors know. So the thing is that you have to focus statement as well. So statement saying oozing with the pus. So oozing pus, it means there is necrosis as well. So also keep the structure in your mind, but think about the presentation as well. So what are the scenario demanding in this time the oozing with pus and you will go with the blood sugar not appropriate here. So you have to manage this condition. So go for debridement first and after that you will do another thing. Yes, first of all, you have to clean the wound and then you will go to the next management. So that's why AMC is tricky, not just keeping this structure in mind, but you have to approach like this. And after that, you have to think about the scenario. So what are the demanding, what are the presentation, the scenario, apply structure on this accordingly. So in this, our question, the patient is having a dirty itself, oozing with pus. So in this case, next step is always you have to go surgical debridement. Like in our hospital, for example, patient is dirty ulcer or oozing and bad condition, you have to go surgical debridement. And after that, you have to start the antibiotic. If firstly you will start the antibiotic without any cleaning the wound, there is no effective antibiotic. Okay, make sense, doctors? So debridement after antibiotic and after that dressing. So stepwise. And after simple after you have to offloading and then you have to refer the patient. And same approach in our hospital as well. Debridement first, antibiotic, then dressing, and then offloading. Doctors, are you with me? Does the things make sense, doctors? So that's why you have to read the stamp carefully. Okay. So what are the scenario here? What at this what condition demanding? So go accordingly. Okay. Next question. Child with the stuttering presented with the mom who is concerned as the child does not want to go to school. He say I incomprehensive sound. Collect dinosaurs and other faces me what see through this. So it means there is incomprehensive sound. So these word didn't make sense, right? Okay. So what is the diagnosis in this case? Option A, GAD. B, social anxiety. Option C, stuttering. Option D, expressional language disorder. And option is Tourette syndrome. Any other doctors? Dr. Danan is thinking very smart way. So the answer is stuttering. Okay, so this is the typical presentation. There is straightforward, the incomprehensive sound, nothing here. So you have to go with the stuttering. Okay. In case of Tourette syndrome, their presentation will be different. Tourette syndrome have another presentation in which we have the vocal uh, vocal tics and motor tics. Motor tics. So this have another presentation. Motor tics mean there is eye blinking, like the child is again and again repeatedly there is eye blinking. And in vocal tics, like there is head jerking, like this movement. Just a second. Okay. So in vocal, there is head jerking. Yes. So vocal and motor tics. So for this, the treatment is important. So treatment of choice. What are the treatment of choice? So treatment, you have to go with the clonidine. So this is the first line treatment according to RSVGP guideline. So clonidine is treatment of choice in case of Tourette syndrome. Or you can go with the, if there is no option of clonidine, you can choose the guanfacine. Okay. So this is also important. So that's why I mentioned treatment here. So in Tourette syndrome, there is vocal and motor tics. And the treatment of choice will be clonidine and guanfacine as well. And this, if symptom, these tics will be present greater than 1 year. So greater than 1 year, you have to make the diagnosis. It is Tourette syndrome. Okay, easy. Move to next. Okay, next question is 25-year-old mother present at 6 weeks who cousin had chat disease. She want to know what investigation to do to check her baby. Okay, so this is 6 week right now. So what you advise to this lady? So option A is chronic villus at 10th week, amniocentesis at 16th week, pubs and knuckle translucency, option C. So what do you think, guys? Okay, so majority with the option A. Okay, so option A is correct. So chronic villus at 10th week, you have to go with the that. Okay. Okay, easy question. Okay, move to next. Next we have tourist goes to Thailand and gets scratched by monkey, but doesn't break skin, no blood, and he wash the hand. So what you do? Option A, no rabies needed. Option B, rabies vaccine. Option C, rabies immunoglobulin. And option D is tetanus vaccine. So get scratched by monkey. Okay, focus on this. But doesn't break skin to no blood. So this is important. There is a no blood, but there is scratch over here. Okay. So some of people with B, some with C. Okay. Okay. So here is the rabies vaccine. Okay. So you have to go with the rabies vaccine. So in statement, you can see that there is a get spread. So it means here this is the recommendation for vaccination. So category 1, just touching or feeding suspected animal, but skin is intact. Okay. So immunization, no need to do. Okay. None. What about category B? Category B, there is a minor scratches without bleeding from contact or lick on the broken skin. So you have to go for medication. So our patient in category 2. Okay. What about the category 3? There is one or more bites, scratches, leaks on the broken skin or other contact that breaks the skin or exposure to the bed. So in this case, you have to go with the vaccination as well as rabies immunoglobulin. Make sense, doctors? Doctors, is it okay? Make sense for everyone? Okay, so our patient belong to category 2, just get scratched from the monkey, but didn't break the skin. So in category 2, minor scratches without bleeding. Okay, no from contact. So this is the vaccination according to Australian guidelines. So remember this. Okay, next question. Next question, 42-year-old woman present with the right upper quadrant pain, tender, petomegaly, and splenomegaly. Cervical lymphadenopathy as well. No fever. Last week he was feeling fatigue and weakness. Same partner for 6 weeks. So in blood investigation. So what do you see? So you have to do peripheral the report already given, atypical lymphocytes and increased lymphocytosis. So option A, EBV, option B, HSV, option C, syphilis, option D, Hep A. Okay, so all of you with option A, intelligent. No, Hep A, no, doctor, this is not Hep A. So this is the Epstein-Barr virus. So atypical lymphocytes is the typical point on peripheral smear, as well as there is cervical lymphadenopathy. Okay, so this is also typical point, as well as splenomegaly and hepatomegaly. So these are the key points to reach to the diagnosis. Atypical lymphocytosis as well as posterior cervical lymphadenopathy, okay, hepatomegaly and splenomegaly. So these are the crucial points. And in some scenario, you will find out that the history like that the patient avoid from the contact sport. Okay, avoid contact sport. So this is also in the history you will find out. How long in this lecture? So we hope so, inshallah, before 9 we will finish this the remaining question as well, inshallah. Okay, so this is the typical point of EBV. Okay, so this is the typical point of atypical lymphocytosis presentation will be cervical lymphadenopathy along with the hepatosplenomegaly. Okay, and we also called this as kissing disease. Okay, so kissing disease we also called as EBV. Mainly this is spread due to the saliva or respiratory secretions. Okay, so this is from the med bullets. The patient present with the fever, cervical, posterior cervical lymphadenopathy, as well as hepatomegaly, a platal, petechia's tonsil exudate. What are the study? In which you will find out there is atypical lymphocytes on peripheral smear. And the second test is the monospot test, always positive in EBV. So this is confirmatory as well. So making the diagnosis based on clinical presentation and laboratory study. So this is from the MedBullish. So our question about the diagnosis and the labs. So atypical lymphocytosis as well as monospot positive. So this is the presenting sign. So the posterior cervical lymphadenopathy extremely important is typical point, as well as there is atypical lymphocytes is extremely important typical points in this case. Okay. So let me show you from the complete guideline from MedBullets. Okay. So classification EBV or human herpes virus. Okay. So risk factor is Asian descent. EBV caused nasopharyngeal carcinoma, living in the endemic areas, and the important one, and it have association with the Burkitt lymphoma. So doctors write down this. So EBV have association with the Burkitt lymphoma. So this is important, and also due to the kissing. Okay. So presentation, the fatigue, pharyngitis, maculopapular rash. So this is the overall feature, but physical examination, you will find out there is a posterior cervical lymphadenopathy, extremely important, hepatosplenomegaly, and the rest of things is you like to remember. What are the lab investigation? There is a atypical lymphocytes on peripheral smear in large nuclei and positive monospot test, IgM antibody detected by the agglutination. So differential, there is cytomegalovirus. You can think. Okay, so what about the treatment? Treatment, basically you have to approach the like symptomatic. So, and also advise to patient to away from the contact sports as well, because these patients have high risk to rupture of spleen as well. So that's why you have to counsel the patient. So patient are risk of the splenic rupture. Conservative, you have to approach supportive care, hydration. If patient is symptomatic, give antipyretic as well. Okay, paracetamol, and hydration and pain management. And after that, we have specific criteria to admit the hospital if the symptom are worsen. And after admission, you can start the corticosteroid. And this is after admission, not overall. Overall, you have to go for the conservative management. Okay. So what are the complication? You can go with this splenic rupture. Sorry, complication is splenic rupture, malignancy, hemolytic anemia, or Guillain-Barré syndrome. Okay. So the prognosis mostly cases resolve. Okay, so doctors, is it okay? My speed is okay or too fast? Guys, it is okay with we have a moderate pace or I need to slow down more? Okay, okay. Thank you, Dr. Dinan. Thank you. Okay, so next question. So 17-year-old girl with history of epilepsy, no control with the carbamazepine, want to start OCPs. So what do you think about this? So option A, continue carbamazepine with high dose OCPs. Option B is increased carbamazepine and low dose OCPs. Option C, stop carbamazepine. Option D, tell her she doesn't need OCP. Okay, majority with option A. Okay, Dr. iPhone will increase the dose. A, Dr. Sana with A. Okay, doctor, mashallah, you are intelligent. So we have to go with the increased dose. The thing is that when patient on epilepsy medication, the OCPs, the contraceptive like OCPs, their efficacy will reduce. So that's why we have to increase the dose of OCP even on carbamazepine. So just we have to increase the dose. So that's why it can meet the effective demand as well. Okay, next question. So next question, farmer came to emergency department with puncture wound. Had TT immunization 7 years ago. After cleaning wound, showing deep wound. What to do next? So recaller didn't mention about the option. So give DTP. So the thing is, had tetanus immunization 7 years ago. Okay, so this point after cleaning wound. So what to do? Just we will go with the complete guidelines. So the question came in any way you can solve this. Okay, so history of tetanus immunization. So, so doctor, focus on this to understand. So that's why you can solve each and every MCQ anyway the question comes. So, for example, history of tetanus immunization, if greater than 3 doses, time since last dose, less than 5 year, and type of wound will be minor clean wound. Okay, are the all other wounds. So minor clear wound, all other wounds less than 5 year of last dose, and history of tetanus vaccination is greater than 3. So there is a no need of TTP combination DT DTAP appropriate. So no need to give the DTP and tetanus immunoglobulin. Doctors focus on this topic. So question here didn't mention about the statement option as well. So that's why if you know this table, you can solve any question in any way. Okay. So that's why I focus on this. So if there is a minor wound and all other wound and history of last dose is less than 5 year and uh, the 3 doses is complete, there is a no indication of a TTP vaccination as well as immunoglobulin. Okay. Second, history is the dose is greater than 3 and the since from the last dose, the time period is 5 to 10 years. So in this case, there is minor clean wound or all other wound, but time duration is increased here 5 to 10 years. So TTP vaccination in case of minor wound, there is no need. But in case of other wounds, you have to go for the TTP vaccination. And the tetanus immunoglobulin, no need, same. Okay, so what about the patient who have greater than 10 year and the doses is complete greater than 3, but the duration is greater than 10 year. In this case, what you do? Okay, so minor clean wound or all other wound. So in both cases, you have to go for TTP vaccination because time duration is greater than 10 years. Okay, but there is a no indication of immunoglobulin, tetanus immunoglobulin. Okay. So what about the less than 3 doses are uncertain? Patient don't know about their vaccination history, uncertain, or patient said that I have only 1 to 2 doses, are uncertain, or don't know. So in this condition, what you will do? So minor clean wound, you have to go for DTP, okay, but no indication of TIG. All other wound, you in this condition where the patient is uncertain about the vaccination history, our dose is less than 3 and there is a big wound, in this case you have to go for both. So only indication of both is tetanus immunoglobulin as well as GTP. Only in case where there is patient is uncertain about the vaccination history or the time is the doses is unknown. So in this case you have to go with the TIG as well as vaccination. Okay, doctors make sense. Okay, so quick summary. So if the history is greater than 3 doses and time since from the last dose is less than 5 year, minor wound or all other wound, there is a no need. Okay, no need of TTP or no need of tetanus TIG. In second case where there is a dose is greater than 3 but a time 5 to 10 year duration. So in this case the minor wound as well as other wound. So in minor wound you can go with the nothing, like no need to give DTAP as well as no need to give TIG. But other cases like other wound, there is uh, like they damage most skin part, major wound. So in this case only you will give the DTAP, but no indication of tetanus immunoglobulin because the patient is know about the history of vaccination and have greater than 3 doses. Okay, so what about the third condition in which greater than 3 doses but history is duration is greater than 10 years? So minor clean wound or all other wound, both cases you have to go with the vaccination and no need of retest. And the only last condition, only in this condition, you will go with the tetanus immunization. Immunization as well as immunoglobulin. In which condition, when patient not know about the vaccination history as well as the doses. So only this condition you will add the TIG or add the detail. I think no, it should make sense. So after that, just give read. So you will memorize it. Doctor, should we move to next? Okay. Okay, next question. Upper and lower proximal muscle weakness and stiffness in the morning. Can't out of car ask for antibody. Option A, anti-CCP. Option B, ESR. Option C is anti-SSP. Option D is anti-cardiolipin. So doctors, what is the diagnosis here? What is diagnosis? PMR, polymyalgia rheumatica. Yes. So in PMR, basically the patient have like proximal muscle weakness, polymyalgia rheumatica, like pain and stiffness in the proximal muscle, like shoulder muscle or hip. Okay, proximally. Often with fever, malaise, or might be the patient have weight loss history. And most of this condition present after uh, greater than 50 year. After 50 year of age, it will be happen, PMR. And patient have proximal muscle stiffness. Okay, pain and stiffness. But there is a no involvement of muscle. Okay, so in this case, the ESR will be raised. Okay, as well as CRP. So these will be raised, but CK will be normal because there is a no any muscle problem here. Okay, so this is investigation. So ESR will be raised, CRP, CK will be normal. You have to start the low dose corticosteroid in this case, and this also have association with the giant cell arteritis. Okay, associated with temporal arteritis. Okay, so this is also important topic for AMC. So in this case, initial you have to go with the PSR as well. Okay, polymyalgia rheumatica, what are the clinical feature? So the patient pain and stiffness in the shoulder and pelvic girdle, morning stiffness greater than 45, difficult with activities, rising from chair, combing hair, dressing, systemic feature, malaise, fatigue, low grade fever, weight loss. So no true muscle weakness, no versus myositis. So there is actually no muscle involvement. Okay. So may coexist with temporal arteritis. So it have association as we discussed. So coexist. Headache in temporal arteritis, there is a jaw claudication as we discussed, headache as well as visual loss. So that's why we discuss you have to start corticosteroid as soon as possible. Okay, so on examination, you will find out that there is a limited shoulder and hip movement due to pain. No muscle tenderness, atrophy, neurological finding normal. So what are the investigation? So investigation of choice ESR and CRP. As well as you can go with the full blood count to check the anemia and platelets, CK normal. In this case, autoantibodies, ANA are exclude mimics hypothyroidism. So this is all about the PMR. So diagnose it will be most of the time greater than 50 year of age, bilateral muscle plus hip stiffness, morning stiffness greater than ESR will be raised. Okay. So response to low dose corticosteroid. So this is treatment options. Okay. So okay, doctors, should we move to next? Is it clear so far? Okay. Okay. Okay, this topic is also important. So, who to prioritize for HIV prophylaxis to reduce its incident and community prevention? So, option A, sex worker. Option B, male to male sex. Option C is immunocompromised. So, who to prioritize? Prioritize. It means who is high risk patient in this case. Some people with A and some with C. Dr. Push Pinter with option B. Okay. Okay, doctor. So, according to Australian guideline, so remember this, it is extremely important topic. So, one of the highest risk in Australian, according to Australian guideline, MSM. So, MSM patient is high risk. So, every 3 months you have to go for screening if the risk factor will be present. So, MSM is high risk. So, in this case, you have to go for HIV prophylaxis in MSM. Okay, so let me show you the guideline. This is important. So uh, for that we will go with the STA Australia. Okay, so doctors, MSM who have sex with men, so this is very high risk patient, immunocompromised. So most STI in men who have sex with men are asymptomatic. The main barriers to STI control are insufficient frequency of testing and incomplete testing in asymptomatic patient. Okay, so testing should be performed all three sites: swab of oropharynx, anorectal, and first pass urine, as well as syphilis serology should be performed. Okay, doctor. So one most important things in case of STI, you have to go for the first pass urine. And as we discussed earlier of the today's lecture, for like UTI, you will go with the midstream. But in case of STI, you have to go with the first pass urine. This is also recalls and important. Note down this. So first pass urine, you can take the because the method of sex you don't know. So that's why you have to go with the oropharyngeal, anorectal, and go with the first pass urine, as well as there is a syphilis serology should be performed every time HIV testing or HIV treatment performed. So pre-exposure prophylaxis effective prevent his HIV infection. All patients who are eligible under the Australian guidelines should actively offered pre-exposure prophylaxis. Okay. So men who have sex with men may be cis or transgender as well as okay. So testing advice. So this is important. So 3 month testing for ST is recommended in all men who had any types of sex with another man in previous 3 months. HIV testing is also available. So patients who are not active or monogamous relationship may be tested less frequently, but at least annually. So if risk factor will be present, so you have to go with the 3 monthly. Otherwise, you can test go for annually. So the site of specimen, the oropharyngeal, okay, NAT, PCR, gonorrhea, chlamydia, and the patient can self-collect it. You can take the collection sample from the patient as well, and you will choose the first pass urine, okay. Anorectal swab, same. So blood, HIV antigen, antibody, if not HIV positive. So this one, the things you must know. Okay, doctors. So same things you have to go with 3 month testing. Screening for Neisseria, gonorrhea as well, because these the STI, Neisseria gonorrhea and chlamydia trachomatis. These two organisms are most common in the uh, pelvic inflammatory disease in case of women as well, and in men also. So you have to screen this. Okay, should be NET PCR according to doctors. Is it okay? The things make sense, right? Okay, so PRP, so pre-exposure prophylaxis is highly effective in preventing HIV infection. Should be actively offered to any person at risk. Okay, any person at risk, you have to offer. All patients taken pre-exposure prophylaxis are eligible for it. Should be tested 3 monthly. So 3 monthly, this patient should be tested. Okay, so patient with any positive STI should be tested every 3 months to detect reinfection, and because they may not be ongoing risk of STI. So you can repeat test every 3 monthly. So even if all test results are negative, use opportunity to educate about the condom use, contraception, HIV, safe injection practice, consent, CST, cervical screening test as well, and vaccination for Hep A, B, and HPV. So educate about this. So vaccination for Hep A, B, if susceptible. Discuss pre-exposure prophylaxis. Consider vaccination for HPV. Discuss the drugs use and harm reduction. So this is all about this. So 90% of the men who have sex with men are tested according to these guidelines. Okay. So these are resources. So doctors STI guideline you have to use for all STI cancer. So this is the method to use. Just here you can see that there is a different topics: anogenital, chlamydia, parasites, central herpes, gonorrhea, hepatitis A, B. So any topics which you want to see, just click here. The topic will be open. Infection associated with sex, bacterial vaginosis is extremely important. Candidiasis, this one is important. Hepatitis C is important. Okay, so the important one: trichomonas, bacterial vaginosis, candidiasis, as well as HIV, gonorrhea, genital herpes simplex, chlamydia, and anogenital warts. These topics you must know, and we already covered in our classes in detail. So just to give you the information about that, just go through it your own time as well. Okay, okay. So the things we discussed. Okay, so 3 monthly testing is required. Okay, next we have 13-year-old came for abortion. 6 weeks ago tested positive and was raped as well. So what do you do? Option A, inform police. Option B, inform sexual assault services. Option C is refer for termination. So this question is also a lot of controversial debates on different groups. So every person have their own opinion. So let's we talk. So Dr. Adnan, Child Protection Services. Dr. Sajid with A, inform police. Okay. Any others? Dr. Pushpinder with option B. Okay. So doctor, important. The 13-year age cutoff is important. Come for abortion. And 6 week test positive was red. So age is important here. And in this age group, if patient is independent, we have to go for the glic competence. What is glic competence? Means the patient can understand the harm and benefit of the any procedure with which she want to do from the hospital? Dr. Emily with A. Okay. Okay, doctor. So the thing is that the 13 year till 13 year you can inform the CPS. So look for CPS. Okay. So recaller said choose TOP. So as I read the topic, please. Okay. So this is the recaller wise. So the correct option you have to look for CPS. If CPS is not in option and age is greater than 13 year, you can go with the informed sexual assault services. But 13 year, you have to just refer the patient to CPS. Okay. So CPS option you have to look. Okay. In case of 13 year, for example, if age is 14 year or 15 year, what do you do? So in this case, you will inform the sexual assault services. Okay, another case, for example, here is 15-year age. So the woman is demanding for the termination abortion, and what you need to do. And woman is also saying that please don't inform to my parents as well and any other family members. So what you should do at this time? So in this case, you have to go for the check for the GLIC competence. So if patient GLIC competence is okay, patient understands the pros and cons of abortion and about the procedure, what they are talking. So then you can go with the termination. Okay. But if patient is didn't able to understand the harm and pros and cons of the procedure, you just give that no. You can apply in this condition. Apply for court, the children court. In Australia, they have children court. Yes, confidentiality respected. So accordingly, we didn't inform even if patient is didn't click competence. So in this case, we will not go to inform their parents. We have to apply for the children court. So this will maintain the patient confidentiality. Okay. Then the court will be take the responsibility how they can manage move next. Okay, so here is the case. So hope so the things more clear to you. So the 13-year-old girl come to GP clinic asking for option regarding abortion. She left home 12 months ago. So this is important and living with his 18-year-old boyfriend. Last evening, she went to party where she came. She became drunk and was forced to having unwanted sex with men. Okay, so she want to know if she could have to any abortion as she get pregnant. On examination, there is no evidence of trauma. Which one of the following you have to notify first? So 13 year of age. Okay. So 13 year of age, you have to go with the CPS. Okay. So option E is correct. So this is the explanation of option E. So this is the different from the incident when a mature child voluntarily involved in the sensual sexual relationship. In such cases, no mandatory report is required as if child is 13-year or older. So if patient is voluntarily involved in the sexual activity and patient know about the pros and cons, so in this case, no need to no mandatory reporting to the children. If CPSP not there, then you can choose the sexual assault services. Okay, you will inform to sexual assault services. Okay. So, when a belief of child sexual abuse or assault is formed, the practitioner should be discuss the mandatory reporting requirement with mature minor and include the following in discussion. So, how the minor would like report to progress, the reference for the alerting, the preferences, and as well as minor views themselves, alert from the child protection services, and further information the mature minor would to have including in the report? Okay. So the child protection services should make mandatory report to police. So this is the responsibility of CPS, not your responsibility to inform the child. So you have to inform to the CPS. CPS will mandatory reporting to police. Okay, so stepwise. So if the mature minor is discussing with the mandatory reporter, determine how do not want police to be involved. The information need to be including in the report. So child protection services and police will take this in account whenever there is no ongoing risk to the child or any other. So simply you just inform to the CPS. Okay. So, so it is always appropriate and advisable to pursue or encourage a mature minor to inform her parents. So, firstly, you have to encourage to mature minor. Mature minor mean less than 18, 16 year of age. So, this is mature minor. So you have to encourage, inform to your parents, her parents, carrier to allow the doctor to do on their behalf. But if mature minor refuse to do, so this is important. So it should be avoided. It is unnecessary breach the doctor-patient confidentiality. So if the patient is not agree, so you have to respect the patient confidentiality. Her school option is okay. So this is the other option as well. So, doctors, thanks for your attention. This is for all about today's session. So, any question from today's discussion, please let me know. Doctors, these things make sense. Are you understanding what we are talking? So, for me, the importance of topic for you is important. So, the way you have to go through with the recall. So, any different way AMC can ask. Doctor, this is only in today's PDF. So this is the end slide. For next, we will, I will make next class for next slide. Okay. Are you doing recalls in the week of February for? Yes, doctor. Inshallah, we will conduct the exam week recalls as well in February. Yes, doctors, I will try, inshallah. But for 2025, if you need, we also make the Q Bank from February 2025 to November, complete monthly calls. And our team is working on that. So I hope so in next week we will launch this as well. So in which you will find out the complete recalls pattern according to the AMC, like percentile, time management, and as well as explanation why the option is wrong, why the correct. You will find out each and everything in the form of, and these recalls in the form of mock test. So after test, you can find the explanation as well. My exam, Dr. Emily, on the Friday. Okay, doctors, don't worry. Inshallah, you will pass. So just keep believing in your hard work. Inshallah, you will do. Thursday, kindly pray. Okay, Doctor, Sahab, we are here. Inshallah, you people will pass. So don't worry. Inshallah, we will continue in touch with you. So don't worry. You are not alone in the journey as well. So our team, our panel are AMC qualified as well as Dr. Myra Chaudhary, AMC qualified, as well as Dr. Midit Haider, FCPS consultant gynecologist, as well as AMC qualified and no in Australia as well. So our team is dedicated to helping all international medical graduates in AMC journey. So don't worry. We will be with you, inshallah, and celebrate your success, inshallah, together. So next class we will announce soon, inshallah. Okay. So doctors, I think no, we should have to end the session. Thank you, doctors, for your attendance. So I hope so you will understand the new things as well. Okay, doctors, Allah Hafiz.